Question 108 reads, what is the patient's overall Canberra caries risk assessment category? So here we have a 26-year-old male patient. His chief complaint is, I've been having a little bit of sensitivity. His background and patient history includes recreational marijuana use. His current findings include no new caries, no restorations within the last 3 years, recession on maxillary right canine and premolar, lives in fluoridated community, and uses fluoridated toothpaste twice daily. We're also given this image. So what is Canberra? This is an evidence-based approach to preventing and managing cavities and patients. How it works is that as a dentist, you take dental and medical history and you conduct a clinical exam. So along with the current findings in the mouth, like their cavities or fillings, you need to take in consideration the patient's risk factors. So that includes deep pits and fissures, their eating habits, their saliva flow and function. You can also manage their caries by behavior and chemical treatments. So that would include how often you schedule them in for regular follow-ups or invasive restorative procedures that they might need. So based on the patient's risk factors, you judge if they're low, moderate, high, or extreme risk. So option A reads low. So considering this patient has 2 risk factors, which are that he smokes recreational marijuana and he has recession, but he has protective factors like he lives in a fluoridated community and he uses fluoridated toothpaste twice daily. So he is not a low risk patient because that would require him to have more protective factors than risk factors. So this is incorrect. Option C reads high, and based on this patient and his risk factors and protective factors being equal amounts, so 2 risk factors and 2 protective factors, high risk patients would require more risk factors than protective factors, so this is incorrect. Option D reads extreme. So for a patient to be extreme risk, they would need to have high risk, so more risk factors than protective, and they need to have hyposalivation. So this is not the case here, so this is also incorrect, leaving us with option B, moderate. So like we said before, the patient has an equal level of risk factors and protective factors, his risk factors being the recession as well as the smoking marijuana, and the protective factors being that he lives in a community with fluoridated water and he uses fluoridated toothpaste twice daily. The patient also doesn't have any disease indicators like a new caries or any recent restorations in the past 3 years. So that puts him at a balanced rate, which is what a moderate risk patient would be. So equal amount of risk and protective factors. So this is the correct answer for this patient.
Each of the following can be a direct problem from at-home dental orthodontic treatment except for one. Which one is the exception? So at-home dental orthodontic treatment is highly discouraged by the ADA due to the multitude of safety concerns, some of which are listed down here. And this is largely due to the do-it-yourself nature without the supervision of licensed professionals, and this can cause poor results as well as safety issues. Option B reads tooth misalignment, and this is something that can occur with at-home orthodontic treatment, so this answer is incorrect. At-home orthodontic treatment usually requires patients to take their own impressions, but there is a high chance of user error in this step, meaning that a poorly fitting appliance may be made, and this can be the cause of tooth misalignment. In addition, radiographs are not taken regularly at in-home orthodontic treatment, and this lack of dental evaluation can also result in tooth misalignment. Option C reads gum impingement, and this answer is also incorrect, as this is something that is likely to occur with at-home treatment. Impressions are never fully accurate and can cause irritation of the soft tissue. And with in-person dental treatment, there are adjustments that can be made chairside to ensure that the aligners are not impinging on soft tissue. However, patients that are pursuing at-home orthodontic treatments will not receive this care. This means that the gums are being pinched with the aligners, and this can lead to irritation and inflammation, and in some cases, also gingival recession. Option D reads problems with the TMJ, and this is something that can occur with at-home orthodontic treatments, so this answer is also incorrect. This can be brought on by poorly fitting aligners and the lack of dental evaluations. In addition, the lack of radiographic analysis or monitoring means that TMJ issues cannot be prevented. This means that A, which reads teeth discoloration, is our correct answer, as this is not a direct problem that can be caused by at-home orthodontic treatments. Usually, we might see tooth staining with fixed appliances, as patients are unable to clean properly between brackets. However, at-home orthodontic treatments generally rely on removal appliances, such as aligners, so proper oral hygiene can be maintained in these cases. So in addition to these 3 risks of at-home orthodontic treatment, the ADA also recognizes a few more, and this includes tooth loss in severe cases, as well as root resorption, and all of these risks mean that the patient will have to undergo corrective treatment, which comes with more time and money spent overall.
Question 83 asks, treatment of patients presenting with an intraoral positive Nikolsky sign will involve which of the following? So here a question tells us our patient has a positive Nikolsky sign. And what that is when you rub on the affected mucosa, the outer layer will shed and leave a tender and pink mucosa, much like this picture. So we see this in pemphigus vulgaris, where it's common to have blisters and erosive skin and mucous membranes. So in pemphigus vulgaris, what happens is that the body creates autoantibodies against the adhesive proteins that help keep the structure of your tissue. So those proteins are the ones that are being attacked, and they're called desmosomes. So option A reads benzocaine. This is a topical anesthetic, and we use it before using a needle to help numb the area, and it gives temporary relief from pain, but it doesn't really do anything for the tender mucosa, so this would be incorrect. Option B reads acyclovir. So this is an antiviral drug that's given to people who have herpes. This is not a viral infection, so this would be incorrect. Option C reads nystatin. This is an antifungal that can be used for fungal infections like candidiasis, but this isn't a fungal infection, so this would be incorrect, leaving us with option D, topical corticosteroids. So in pemphigus vulgaris, the cells above the basement membrane are the ones that are affected, and the cells in the basement membrane are still intact. It's a painful condition, and by using topical corticosteroids, it prevents the cells from producing inflammation, and that'll help with keeping the top layer from getting rubbed off. So it doesn't cure pemphigus vulgaris, but it helps manages the effects of it, and it helps with the painful ulcerations. So this is the correct answer for this question.
Include lower cumulative lifetime alcohol consumption in females, because this is believed to have nothing to do with color perception. This question is asking which of the following findings can only be present in an unerupted tooth. This means that some of these may be seen in both erupted and unerupted teeth, but only one always has to be present in an unerupted tooth, and that would be C, the dentigerous cyst, and you can see a picture of what one would look like. Now, this is the most common developmental odontogenic cyst, and it develops due to the accumulation of fluid between the crown and the reduced enamel epithelium, which eventually forms the epithelial lining of the cyst. To be a cyst, every cyst has to have an epithelial lining, and this reduced enamel epithelium is what becomes that lining. The reduced enamel epithelium is also an essential structure of tooth formation or odontogenesis, and the location of this fluid accumulation leads to a radiographic presentation that looks like a bubble attached to the cervical area of the tooth. If you look at the picture, you can clearly see this well-defined unilocular radiolucency and how it kind of looks like a bubble or like a cap on the tooth. Now, this lesion is always associated with the crown of an unerupted tooth, always associated with the crown of an unerupted tooth, and the cyst is attached to the CEJ area. This is most common in the mandibular third molar, followed by the maxillary canine, maxillary third molar, and mandibular second premolars, which if you think about it kind of makes sense. Your wisdom teeth are your last teeth to erupt into your mouth, so they're unerupted usually, and they're often impacted. Even more reason that they're unerupted, so it makes sense that we're seeing this dentigerous cyst in that area. It's usually seen in the second and third decades, and it's usually asymptomatic, but it may have swelling. Treatment for this lesion would be surgical removal of the tooth and cyst. Now, although this is the only lesion that must be present in an unerupted tooth, let's go through the other answer choices, talk about what they are, and how they're similar and different to the dentigerous cyst. And we'll start with the lateral periodontal cyst. Now, this is a non-keratinized developmental cyst occurring adjacent or lateral to the root of a tooth, just like the name suggests, and you can see that in the picture. It's thought to arise from the rests of dental lamina and usually affects the mandibular premolar, canine, and lateral incisor area. It is asymptomatic, is usually seen in the 5th to 7th decades, and it doesn't cause any problems for the patient. Radiographically, it presents as a radiolucent, unilocular, or multilocular lesion that is usually less than 1 centimeter in diameter. Treatment for this lesion is curettage with an excellent prognosis. Now, how is this similar and how is this different from our dentigerous cyst? Both are developmental cysts, more common in the mandible. Both are well-defined unilocular radiolucencies that are usually asymptomatic. But how are they different? Now, these are more common in the premolar canine lateral incisor region rather than the third molar region that we saw for the dentigerous cysts. The dentigerous cyst was also located on the cervical aspect of the tooth attached to the CEJ rather than adjacent to the root of the tooth like we see here. And most importantly, the lateral periodontal cyst is not solely present in unerupted teeth like the dentigerous cyst was and like what's important for this question. Next, we have the radicular cyst. Now, this is also known as a periapical cyst and is actually the most common cyst of the jaws. It is an inflammatory odontogenic cyst believed to originate due to inflammatory stimulation of the epithelial rests found in the PDL. This is asymptomatic and is always associated with non-vital teeth. That's a big important thing to know. If this becomes secondarily infected or is large in size, it may cause swelling or pain. Radiographically, this presents as a round to ovoid radiolucency at the apex of a tooth alongside the loss of lamina dura, and you can see that in this picture. The treatment for this would be endodontic therapy. It's a big cause for a root canal, an apicoectomy, or extraction with curettage. Now, how is this similar and how is this different to a dentigerous cyst? These are both odontogenic cysts that are asymptomatic. They're both very common, and they both present as well-defined radiolucencies. But how is it different? Now, this is an inflammatory cyst and not a developmental cyst. The radicular cyst is located at the apex of a tooth and not at the cervical aspect attached to the CEJ that we saw in the dentigerous cyst. And most importantly, once again for this question, this does not solely present in unerupted teeth like the dentigerous cyst does. And finally, we have the cementoblastoma. Now, this is a benign tumor of odontogenic ectomesenchyme, specifically cementum-like deposits produced by cementoblasts, which is why it's called a cementoblastoma. This is usually seen in patients under 25 and is most common in the mandibular molar region, especially affecting the first molar. This lesion is slow growing and exhibits pain and swelling in 2/3 of the cases, so it usually has pain and swelling. It characteristically looks like the tooth almost has a boot or a shoe, and this is due to the lesion being uniquely fused to the root. So we see this lesion and we see that it's fused to the root. Radiographically, it presents as a well-circumscribed radiopaque mass with a fine radiolucent border that once again fuses and usually obscures the outline of the tooth root. It can also cause root resorption as well. Treatment for this lesion is surgical extraction of the involved tooth with enucleation of the lesion. Now, how is this similar and how is this different to our dentigerous cyst? Now, both are more common in the mandible and affect the same age range, but that's about it. I mean, they both affect teeth, but how are they different? Now, this is a benign tumor of cementum-like tissue, and it's not a cyst. This lesion is always located at the apical and not the coronal portion of the tooth because it has to be attached to the roots. That's where cementum is. And the dentigerous cyst, which is seen coronally and attached to the CEJ. So they're in very different regions and locations of a tooth. Now, radiographically, this is radiopaque rather than radiolucent. And most importantly, once again for this question, this is not solely present in unerupted teeth like the dentigerous cyst was for this question and always is associated with unerupted teeth. So when we're asking about what can only be present in an unerupted tooth, the correct answer here would be the dentigerous cyst, which if you think about it, where this lesion is located, covering the top, the coronal portion of that tooth, once it erupts, there's no space for this lesion to even be present. So it's always going to be present in an unerupted tooth. This question is asking the presence of Savant bodies on biopsy is characteristic of which condition. Now, this is a pretty straightforward question. You either know it or you don't. So let's go ahead and make sure that you definitely know it if you get this question on the boards. Now, Savant bodies should always be associated with C, lichen planus. Now, let's go ahead and talk in depth about lichen planus, and then we'll go ahead and talk about these other answer choices and focus on the histology for them, because that's what's being asked in this question. So lichen planus is a chronic immune-mediated disorder that can be cutaneous or mucosal. Cutaneously, you'll see these purple, itchy papules with these lacy white lines known as Wickham striae, especially on your wrists and lumbar regions. Oral lichen planus has two forms, reticular and erosive. Both of these forms may occur alone or with skin lesions and are usually seen on the bilateral buccal mucosa, the tongue, and gingiva, but can really be seen on any intraoral surface or the lips. So the reticular form of oral lichen planus is the most common, and it's characterized by those same lacy white lines known as Wickham striae. So Wickham striae is with C, lichen planus. Now let's go ahead and talk in depth about lichen planus, and then we'll go ahead and talk about these other answer choices and focus on the histology for them, because that's what's being asked in this question. So lichen planus is a chronic immune-mediated disorder that can be cutaneous or mucosal. Cutaneously, you'll see these purple, itchy papules with these lacy white lines known as Wickham striae, especially on your wrists and lumbar regions. Oral lichen planus has two forms, reticular and erosive. Both of these forms may occur alone or with skin lesions and are usually seen on the bilateral buccal mucosa, the tongue, and gingiva, but can really be seen on any intraoral surface or the lips. So the reticular form of oral lichen planus is the most common, and it's characterized by those same lacy white lines known as Wickham striae. So Wickham striae is really associated with lichen planus. It's a big buzzword for this condition. The erosive form of oral lichen planus is more symptomatic, and it's characterized by shallow ulcers, peripheral erythema, and radiating white lines. Now, most importantly is the histopathology. Lichen planus is known for displaying these Savant bodies, and you should always associate this condition with them. But what are they? They're ovoid, eosinophilic bodies located near the basal epithelial layer. They're formed due to liquefactive degeneration of basal epithelial cells and keratinocytes. Kind of a mouthful. What's really important is that you just associate these two together. But there's other important findings for lichen planus when we do the histopathology. We also see varying degrees of hyperkeratosis, atrophy, or ulceration, and we also see an absence of these rete ridges or sawtooth rete ridges. So they usually don't present these ways, but in this condition, we either see sawtooth or pointed formation of these rete ridges, or they could be completely absent. So it's other important information that you could be asked about for the histopathology of lichen planus. Next is pemphigus vulgaris, which is another immune-mediated mucocutaneous condition, and in it we see autoantibodies destroying desmosomes, which are responsible for bonding epithelial cells together. So by destroying these desmosomes, you get a split that develops in the epithelium and leads to blister formation. So clinically, we see flaccid vesicles and bulla on the skin. Orally, they might have oral lesions, they don't always, but we would see superficial ragged erosions and ulcerations on any mucosal surface. This condition is notably positive for the Nikolsky sign as well. Now, most importantly, the histopathology. So when a biopsy is done, the histopathology will show intraepithelial or suprabasilar clefting, as well as acantholysis, which is a breakdown of the spinous layer where cells are appearing to fall apart. So you can see these cells kind of falling apart when you do histopathology on this condition. We do not see Savant bodies in this condition. That's the most important thing. Next is erythema multiforme, which is an acute onset ulcerative disorder of the skin and mucous membranes. Clinically, the patient will experience prodromal symptoms a week before, including fever, malaise, headache, and sore throat. The presentation of this disease can have varying degrees of severity, but will involve affected skin and at least one mucosal surface affected. On the skin, we see these round, dusky red patches known as target or bullseye lesions, and mucosally, we see characteristic hemorrhagic crusting of the vermilion zones, which is what you're seeing in this picture, as well as shallow erosions and ulcers with irregular borders. Most importantly, histopathology. When a biopsy is done, the histopathology shows subepithelial or intraepithelial vesicles, necrotic basal keratinocytes, and mixed inflammatory cell infiltrate. So it's totally different than what we saw for our lichen planus. And most importantly for this question, we do not see Savant bodies in this condition. And lastly, we have mucous membrane pemphigoid. This is an immune-mediated mucocutaneous blistering condition as well, and it's called pemphigoid because it's similar to pemphigus vulgaris, which we talked about earlier. Clinically, this can affect any mucosal surface, surface and occasionally affects the skin. The most common clinical sign of this condition is desquamative gingivitis or peeling of the gingival tissue. We also see erythematous and ulcerated gingiva with the loss of stippling. And the most serious or significant aspect of this condition is its ocular involvement. So you can get this scarring and it can lead to blindness. So a patient who has this always needs to be referred to an ophthalmologist. This scarring can also be seen on the skin with the cutaneous lesions. Now, once again, most to an ophthalmologist because of stippling. And the most serious or significant aspect of this condition is its ocular involvement. So you can get this mucous membrane pemphigoid. This is an immune-mediated mucocutaneous blistering condition as well, and it's called pemphigoid because it's similar to pemphigus vulgaris, which we talked about earlier. Clinically, this can affect any mucosal surface and occasionally affects the skin. The most common clinical sign of this condition is desquamative gingivitis or peeling of the gingival tissue. We also see erythematous and ulcerated gingiva with the loss of stippling. And the most serious or significant aspect of this condition is its ocular involvement. So you can get this scarring and it can lead to blindness. So a patient who has this always needs to be referred to an ophthalmologist. This scarring can also be seen on the skin with the cutaneous lesions. Now, once again, most importantly, histopathology for this question. When a biopsy is done, the histopathology shows separation of the epithelial layer from the underlying connective tissue at the basement membrane zone. So this is due to the loss of hemidesmosome proteins, which typically hold these two tissue layers together. They typically hold this epithelial layer and the connective tissue layer together. So when we get a loss of these proteins, we get this separation in these two layers at the basement membrane zone. Most importantly, we do not see Savant bodies in this condition. So when we're asked the presence of Savant bodies, where are they seen? They're only seen in lichen planus out of these answer choices. And that's something really important to know is your histopathology. So this is a pretty straightforward question. We either recognize this lesion or we don't. So let's make sure that we always recognize it. So we're asked to find the most appropriate diagnosis for this condition. So let's kind of talk about what we're seeing in this radiograph. We see that we are, first of all, in the posterior mandible. It's always important to note where we are because certain lesions have trends for being found in certain locations. So it's good to know that's where we are. Also, we see this radio-opaque, calcified mass, and it's very, very opaque. It's almost more opaque than the surrounding bone. It looks more similar to the tooth structure that's nearby. That's how bright, white, radio-opaque it is. So that's an important thing to note. And we see this narrow radiolucent rim, almost like a bubble around it, and we see that it's overlying an impacted tooth. So that is all important information that we can put together to diagnose this as a complex odontoma. So let's go ahead and talk about what an odontoma is just by itself, because as we can see from the answer choices, it could be compound or it can be complex. So let's talk about what an odontoma is, and then we can kind of break it down between the two forms. Now, an odontoma is a tumor of odontogenic epithelium and odontogenic ectomesenchyme. So what does that really mean? Now, if we break down the word odontoma, oma would mean tumor, and odont means tooth, so like odontoblast, odontogenesis. So we're really talking about a tooth tumor. We are talking about a lesion that is made up of tooth structure. So like we said that lesion is really radio-opaque, almost similar to the enamel and the dentin in the nearby tooth. That's because it is a calcified mass of tooth structure, of dentin, of enamel, of cementum. That is what we're seeing. It's an odontoma. It's a tooth tumor. So that's what we're seeing here, and that's what an odontoma really is. Now, they are seen in young patients, with 14 being the average age, and they're usually associated with failure of tooth eruption, just like we're seeing in this lesion. So how do we know this is a complex odontoma versus a compound odontoma? Now, complex odontomas are usually found in the posterior jaw, just like we're seeing with this lesion. So like I said, location is very important. A complex odontoma also presents exactly how we described this radiograph. So it is a radio-opaque, calcified mass with the same density of tooth structure. It also has that narrow radiolucent rim, and it's usually overlying an impacted tooth. So that's how we know what we're seeing. Now let's go ahead and talk about a compound odontoma. So this is also an odontoma, and just like we said, it has the same composition, and it's seen in the same group, But how is it different? Now, a compound odontoma is usually seen in the anterior jaw versus the posterior jaw like we saw for that complex odontoma. Also, radiographically, they present so differently. You will not mistake these two.